it's my great pleasure and honor to introduce Dr. Lisa Armitage to the TB eco community. Lisa holds MD, PhD degrees, and she's a professor of infectious diseases, internal medicine, and also pediatrics at the University of Texas at Tyler. She is a co-medical director at the Heartland National TB Center, as well as a medical director of San Antonio TB Clinic. Dr. Armitage gives many talks nationally and internationally on tuberculosis, and she cares for both adults and pediatric patients with the TB at the large metropolitan clinic in Texas. In addition, Lisa conducts biomedical research in the pathogenesis of TB. Also, I want to congratulate you, Lisa, that Dr. Armitage is a recipient of the MTCA William Stead TB Clinician Award this year. I'm also personally grateful that Lisa mentored me when I took a leadership position at the National Society of TB Clinicians several years ago. As the TB eco community requested and nominated Lisa to give a talk on the use of steroids among TB patients, we asked Lisa, and she kindly accepted the invitation. Without further ado, Lisa, please.
All right. But first, Masa, thanks for the invitation. So Masa just asked me, he's like, can you give just a brief talk on steroids and TB? And so because I'm chatty and tended to just like to be chatty, I try to restrict the slides down to a number where I can leave some time at the end for discussion. So I'm going to try to kind of go through them, not, so quickly that it's not clear, but to try to get through them so that we can have some points for discussion. The objective really is to try to discuss the appropriate use of steroids in the management of patients with TB with the purpose of improving outcomes. And we'll talk, but everybody's kind of outcomes when they measure them are a little bit different. And then also to talk about some of the commonly used steroids and how to apply steroids to achieve, optimal patient outcomes. So actually, this paper is referenced in a lot of the papers about steroids and TB. And this is a paper from 1959. I thought this was like one of the coolest things. I was a little horrified when I read all of the patients in this study were treated with isoniazid, streptomycin, and PAS. And in 1959, that's what we had to treat patients with. So they looked at, in this paper, they had 36 patients with what they called acute TB. These are people with newly diagnosed tuberculosis, and 107 patients with chronic TB. So these were patients who had TB, they knew had TB and had that for at least 6 months, and were not having any signs of improvement. So in the 36 patients, when they gave them steroids, they noted that frequently they had a rapid objective improvement. So of note, the patients all felt better. When they were given the steroids and they gave them prednisone, they felt better. But there was an objective improvement in their measures of the patients. So one of the things that you look at, the temperature chart of the patient here, this patient is consumptive and fevering. So fever's dancing pretty much between 100 and 103. And then at the point they gave the steroids, immediately the fevering stopped and the patient started, started to have a normal fever curve. 32 patients recovered, like they say recovered, with isoniazid, streptomycin, PES, and steroids. And 8 of these patients had TB meningitis. So they had 15 of 20 patients. They had 20 patients in the 107 of chronic disease that they were expecting to die, and 15 of these patients recovered. So, it's just interesting that, with a lesser, with basically a regimen that was in what we would consider far inadequate regimen back then, they actually had patients that recovered with just adding the steroids. But this was the first time I'd seen the fact. So remember, one of our risk factors for tuberculosis is patients who have had at least a month of about 15 milligrams per kilogram of steroids. They've noted in this paper the fact that corticosteroids can reactivate TB. This is the first time that I had noted that, and that this is oftentimes overlooked. The Cochrane review, I was trying to find a review that just kind of outline the benefit or non-benefit of steroid therapy in management patients with tuberculosis, with pulmonary disease. So they had a review of 18 trials that was almost 4,000 patients. They said that, so the one thing that, if you look at the papers, they always measure death and sputum conversion at 2 months. Everybody measures that. There's a lot of other stuff that they measure, but that was the one thing that they were able to consistently measure. And it didn't show any reduction in all-cause mortality. So it didn't prevent death. And it also didn't result in sputum conversion, a better, an improved sputum conversion at 2 months or at 6 months. But what they did find is that when you gave steroids to patients who had pulmonary tuberculosis, that it did increase weight gain, which kind of makes sense. It decreased the length of hospital stay, and it increased the clinical improvement within 1 month. So by the end of treatment, this had all kind of faded. But when I look at papers like this, I'm like, okay, it didn't decrease deaths, which is always nice, but that's kind of the ultimate. How many of our patients die of TB? If we're kind of getting on it early and we're getting to where we need to be, pretty much we're sparing the patients anyway. But if I can get a patient to gain weight and decrease the hospital stay and increase the clinical improvement at 1 month, and the patient feels better and clinically is improved, I'm thinking on some level that might be some winning. The second Cochrane review is on corticosteroids and TB meningitis. Now, this is the one that we all, tend to know that we're using it for. So they looked at 9 trials. This was 1,337 patients with 469 deaths. So, deaths being a lot more in meningitis with a lot more severe disease. And in this case, corticosteroids did reduce death in this group, at least in the short term. So they looked at patients at 1 year and 5 years after, from the start of treatment. And there was a reduction in death at 1 year that was not found in 5 years. So whatever patients were dying from seems like they were going to die from anyway. But I thought that was another interesting thing. I'm like, I'm trying to cure the person's TB and I'm trying to keep them from dying. And whether or not they live 5 years after that, I'm not sure why that is as important, unless it's, there's some post-tuberculous disease that is causing that, but they didn't really talk about where that was from. So corticosteroids have no effect on the number of people who survive without disabling neurologic deficits. So it didn't seem to improve the neurologic outcomes, but they said this outcome was less common than death. So apparently the numbers were smaller in the number of people who had neurologic deficits. And it was interesting again for me, but it didn't seem, they did say may, because there were some papers that showed that it did show some improvement. So if you gave people steroids, they had some improvement in their neurologic deficits, and there were some that did not. So they put a may, but they did mention that it may not, but it could. So this is important. There's no difference, because in this group, like where you usually use steroids in the short term, and I get all kind of heartburn, giving heartburn to the pediatricians, you're going to decrease their bone density in teenagers. And I don't know what they're doing. Think that the steroids are doing to children that are going to permanently cause them some problems. But they look at specifically in the groups that had steroids versus not. There was no difference in adverse effects like GI bleeds, invasive bacterial infections, hyperglycemia, and liver dysfunction. Now, the hyperglycemia, I've seen that in my diabetics. If I put them on steroids and the chase is on, they're really having, problems managing their hyperglycemia, but this was all comers, not patients necessarily who had diabetes. So it doesn't seem like all of the things that we're worried about when we give steroids long-term for our patients with hepatitis, with meningitis, that we need to be as concerned. But they did know that the number of HIV people included in the review was relatively small, so they weren't sure if this was relevant to patients with HIV. So let's go to our actual guidelines. These are our treatment guidelines for TB, and look at what the recommendations in there are. And so the first time they talk about prednisone in steroids is with severe IRIS. So you have patients who have HIV and TB. And when you start treating the TB, the bugs start dying, you increase their antigen load, and their immune system now is recovering and starting to cause bystander, damage to tissues, trying to kill that bug. So their recommendation, 1.25 milligrams per kilogram. They actually gave a range, 50 to 80 milligrams of prednisone. And then they recommend 2 to 4 weeks, and then a wean over 6 to 12 weeks or longer. So I'm not, that's a lot of kind of gray area. I will just tell you, I always start at 60. The old guidelines from 2003 specifically said start with prednisone 60. That just stuck in my head. I think anywhere in this range, 50 to 80 is more than enough. It's probably fine. Depending on how, and I don't know where they get these teeny little people from. Down in Texas, everything's bigger, including our patients. Our patients are fluffier down here. They're just a little bit bigger. So if I'm doing, a 60 kilogram patient, yeah, sometimes, mostly they're closer to about 70, 75, 80, so they're a little bit bigger, but usually 60 milligrams for me has just kind of been one standard number that has worked. But I really think anywhere in this range is probably fine. The 2 to 4 weeks, I tend to think of, okay, paradoxical worsening or IRIS tends to occur 2 to 4 months after you start treatment. So if I treat 2 to 4 weeks and I wean in 6 weeks, I'm weaned in 10 weeks, that's like what, 2.5 months, and I'm just starting my IRIS period. So I personally do for the first 2 months, then I reevaluate the patient. I start my wean then. So I personally tend to go a little bit longer, but really here's where the guidelines is. And just as long as you're treating and then weaning slowly should work. TB pericarditis, they didn't find any real evidence that because it used to be in our old guidelines, it was meningitis and pericarditis were the A level A level for use of steroids. But then the pericarditis got bumped out when they re-reviewed the data. But if you have a patient that has a lot of inflammation, it's a strong inflammatory response, they are at risk for constrictive pericarditis, and they actually recommend that you might want to use steroids in patients with large pericardial infusions or at high risk for inflammatory complications. Because remember, we're doing two things. We're giving them the TB drugs, and that's killing the bugs, but it is not decreasing the inflammation. So if you have a patient and you have worried about inflammatory complications, give them some steroids and then wean them off. TB meningitis, they recommend dexamethasone or prednisolone, and then they recommend a taper over 6 to 8 weeks. So for the HIV guidelines, I just wanted to pull those out. Specifically, they have, some recommendations on treating IRIS in patients with moderately severe paradoxical TB. IRIS treatment with prednisone is recommended. So their prednisone, very close, but a little bit higher, 1.5 milligrams per kilogram per day for 2 weeks. And this was based on a study, followed by 0.75 milligrams. So basically half that. And so they did note that in a subset of patients, 4 weeks was not nearly enough. And in that case, they recommended a more gradual taper over 2 to 3 months instead of just 2 weeks. So again, I just want you to note that IRIS, like paradoxical worsening, tends to occur about 2 to 4 months after the start of TB treatment. And having your wean overlap with that I feel like keeps you out of trouble. So when you should absolutely consider steroids. TB meningitis as a grade A recommendation. Also, something people don't think about, if you have intrathoracic lymph nodes that are threatening an airway, we see that in pediatrics more so than we see in adults. But if you have a huge lymph node and it is compressing an airway, that lymph node is likely to get a little bit bigger before it gets smaller. So if it's already on your chest x-ray showing that it's narrowing an airway, threatening an airway, you may have a child that stops breathing in their sleep. Strongly recommend that you add steroids on to that child in that case. And the dose, the pediatric doses, 1 to 2 milligrams per kilogram. So the adult dose is very similar to the adult doses, and they overlap. But children, 1 to 2 milligrams per kilogram. But I would also offer that you should consider using steroids if you have iris or paradoxical worsening, pericarditis, and then lymph nodes obstructing any other lumens besides. So if you have abdominal lymphadenopathy and you seem to be having some problems with GI symptoms, I would do the steroids for that too. Anywhere that you need to shrink something and know that the drugs are just killing the bugs and the immune response is what you need to touch on next, I would do that. So which steroids are best? Everybody has their kind of voodoo that they do. We do prednisone because it's on our formulary down here in Texas, and we can give it to the patient for free as part of their treatment. A lot of the patients come out of the hospital on dexamethasone. You see at the bottom of the table here that that's a longer acting steroid, so they like those. But the important thing is if the patient's coming out of the hospital, you don't want to start changing that steroid dose really aggressively. So you want to just make sure that you convert from what they were taking in the hospital or what they were taking or able to get. I will say that prednisone is on the Walmart $4 list, like 20 milligrams of prednisone. You can get a month worth of that on the $4 list. So that might be something that you consider, if the patient is having to pay. But this is a table from, and I list the site down there, but if you type in steroid conversion table or steroid converter, they will pull up sites that will let you put in the dose of the steroid you're using, and it'll spit out the dose of the steroid that you're switching to. I would just recommend getting it correct, but pretty much all of the corticosteroids are going to act similarly. It's just either short, intermediate, or long acting. So whichever one you have access to, whichever one the patient pays less for, or whichever one that you're most comfortable with, they're all acting about pretty much the same. So weaning, oh, this is the magic. This is like glitter and unicorns, basically. Golden-haired unicorns, rainbow-haired unicorns. Like there's no data. They're like, so, they always tell you to wean over this amount of time, but they don't tell you how to get there. So my suggestions are just wean slowly. If you have large lesions, wean slowly and listen to the patient. The patient is with themselves every day. They can tell you if you have a return of headache, if they have memory lapses, if they have any other kind of symptoms that they had prior to starting the steroids. If they note that, and just go back up to the dose they were tolerating, stay there until the dose, until they'll stabilize with that, and then just start your wean a little bit more slowly. I tend to go from 60 to 40 pretty quickly, but after that, I like 2 weeks, two week intervals. I'm just comfortable with that because I know we can monitor the patient. So I will, get them to 40, and then I'll say, okay, in 2 weeks, we're going to cut you down to 20. And then 2 weeks after that, they come see me. So I've had one wean. I see the patient again. I wean again at that point if they're doing well. I do from 20 to 10 and then 10 to 5. And then usually I'll do 5 for about 1 week because supposedly your adrenals should be waking up and picking up for you at that point. So that's just kind of my wean. Some of them go more slowly. If I have larger lesions and they're struggling, I will go from 40 to 30 to 20 to 15 to, so like sometimes I add 5 milligram increments in there. But, make sure if, you're looking for reasons for worsening disease before you just assume that, it was a drop in the steroids. You're monitoring the patient, you're looking for other reasons, but we have restarted the steroids, stopped all the way, gotten a patient out of the hospital. They had already stopped the steroids. And then somewhere in that, 2 to 4 month period when paradoxical worsening or iris can occur, the patient had a worsening, I put them right back on the steroids. But I'm also looking for making sure that there's no reason that I have susceptibilities. I have good evidence that the patient's not having diarrhea or vomiting or not absorbing the meds. If that's all checked out, then I'll put the steroids back on. So that is all that I had for, like I said, try to keep it short and sweet and something that you can find useful.